All right, everyone, thank you for joining today. For our session, for those of you I haven't previously met, I am Kelly Guthrie, and I am the new WVCTSI Echo Coordinator. I kind of took Elizabeth's spot whenever she had left, and I will be in charge of your sessions moving forward as far as I know. If we want to first start by introducing everyone. Kaylee, if it's all right, we'll start with you.
Hi, I'm Kaylee Berner. I'm a nurse practitioner with infectious disease here at WV Medicine.
All right, Carmen.
Hi, I'm Carmen Rexhard, family physician at Pendleton Community Care in Franklin, West Virginia. And with me today is Tatiana Hendrickson, who is a third-year medical student at WVU.
All right, Rachel.
Hi, everyone. Rachel Mitchell, pharmacist here at the WV Medicine Specialty Pharmacy.
All right, and Dr. Gulifoose.
Yes, John Gulifoose, one of the infection providers here at Ruby.
All right. So I will stop sharing my screen. So if you'd like to share your screen, if you have slides. We don't have a case to present today. If anybody has anything that they would like to kind of present to the group offhand, get some recommendations or feedback, you can now, or if you want after Dr. Gulifoose goes over everything, it's really up to you guys.
Kelly, is not letting me share.
Oh, give me 1 second. That's a me problem. All right, let's see if that'll work now.
Okay. Can you guys see that?
Yes.
Thank you. I always find a PowerPoint for 3 people overkill. So Dr. Rexroad, Tatiana, Kaylee, and Rachel, hi. I'm John. I'm just kidding. I know all of you so well, except you, Tatiana. I'm assuming you're a third year? Fresh?
Yes, so I just started my rotations this past month and I'm with Family Med.
Oh, congratulations.
But you've given me, I think, an infectious disease lecture when I was a second year.
My sympathies, I'm sorry.
I was saying you were great, so I had a good time.
No,
I'm excited.
This was well, what I want to do is, ask you what questions you all have online. So I have a PowerPoint that addresses everything that well, I shouldn't say everything that you might want to know, everything that I know on Lyme disease. There's a label today as us talking about treatment and prevention. If that's what people are interested in, I could certainly go that route. We could go with more of a Q&A type of approach either, or I can go over an abridged version of this slide that I often I don't give patients the PowerPoint, but I give them the highlights of this PowerPoint from my memory, and have found that rewarding. Well, actually, hopefully rewarding to the patients insofar as to educate them quickly on Lyme disease and make sure they're experts in it by the time they leave the visit. So were there any particular questions that anybody had on Lyme, or any cases they wanted to discuss, or questions, or personal tick encounters, anything else? Otherwise, I'll blabber on. Oh dear.
I'm always interested to hear the spiel you give patients
Oh, okay. Who
because
is
you're
that?
so good at
Oh, that's Kaylee.
Kaylee.
Oh, you're
I'm
so
eating my pizza.
I
Sorry,
was gonna say-
but
As a parent who has
Dr.
pulled
Gulifoose,
ticks, I was going to echo
Yeah.
that. As a parent that has pulled ticks off of their child, and it feels like I've pulled more ticks off of her in her short life than I have in my whole life as a kid
Yeah.
who grew up in the woods. I'd love to hear what you tell parents.
Okay.
yeah,
Patience.
John gives the best. Yeah.
No, I promise I don't. It's people think I'm dumbing it down to layman's terms, and then the sad reality is it's actually my terminology. So it's just at the level of third grade where I live. So I guess I'm going to run through and just highlight the slides that matter since we have nothing but time today. And you remember this was described by a rheumatologist, and a rheumatologist still can play an important role in this disease process. So, and the word oligoarthritis is one of my favorite because it's implying small number of joints really be involved. And again, it was a tick. We all know that. Blah blah blah. The cool part about the tick is that it really actually it's not cool. There's nothing cool about the tick. It gets infected after it's born, and it can get infected usually not from a deer. It seems like deer always get blamed, but it's often a bacteremic rodent that it feeds on and gets sick. The problem is they're tiny, like itty bitty tiny. If anybody's pulled one off of themselves or a patient, you more feel them than anything else because it looks like an imperfection, a freckle, a little whatever. And then, but then you realize that's growing with time, and they're just tiny. I personally cannot estimate the degree of engorgement of a tick. I universally think that these tiny nymphs are not engorged, and it turns out a lot of times I'm wrong when the lab will tell me. So I don't personally use this engorgement time. To me, I can't tell the difference between an engorged nymph and a non-engorged nymph until it's gloriously obvious. But just if it's embedded, I worry. This is a slide that's incorrect, and I just wanted to show you a cool thing. This shows where the Ixodes tick is. It's all over the East Coast, but this shows you that Lyme disease is really not all over the East Coast. And so there's some theories as to why it's not in the deep South. If I have time, I'll talk about it. But we're basically in an endemic zone now. We're in a very, very, very endemic zone now. And yeah, and anyway, that happened with time. It didn't used to be here in the early 2000s, and now it's here in a major way, going up and up and up and bad things. And it's not just deer, it's all mammals and other critters and so on and so forth. So where I usually start, so I say, hey, when Lyme disease was first described, so I'm going to go a little bit out of order. I say when Lyme disease was first described, a lot of people went untreated. And so I start with this as an initial message to give a patient. What's the most important message to get across is that Lyme disease isn't going to kill you for the most part. And so you can see this giant case series of 100,000 people with Lyme disease, and almost nobody died, and everybody got better. And that's even without treatment. So I talk to patients about, not looking purely at the internet, because the internet only has bad news. What good news do you hear from the internet? You look online, the sky is falling, the world's burning, and we all have until November till life as we know ends. But especially with regard to Lyme disease, you won't find any good news. And the good news is buried in history in the 1970s and 80s. And that's it doesn't kill you and it gets better. The next thing I educate patients on is this little thing. I say, hey, it's a cool looking microbe, but it's actually very, very genetically simple. Very, very tiny number of genes. And if you think of an organism's genes as its capacity to do a lot of evil things, that's a comforting statement. And what the functional consequence of a small genome equates to in terms of clinical medicine is number one, this is a bug that itself, the bug does not tend to hurt you. It tends to be the immune system hurting you. And so the majority of symptoms seen with Lyme are not from proteases or toxins. That's very much unlike staph or Pseudomonas or strep, where we know it's the bug that hurts you. And so what I often tell people is, hey, have you ever had strep throat? Most people have had a strep throat. And I say, when you have a strep throat, you have this microbe in the back of your throat making proteins, poisons, and toxins. And the second you take your penicillin, within a day or two, you kill the bug and you feel better because it was the bug that was the problem. With Lyme disease, it's too simple. It doesn't even make any of these proteins, poisons, or toxins. And so the functional symptoms you experience are actually from your own immune system. Okay. And that's going to be really, really important for the patients to understand when we talk about their expectations for clinical improvement. One of the other things I do teach them is this simple microbe does not become antibiotic resistant. And that's a comforting thing. You know, a lot of spirochetes have maintained exquisite sensitivity to a lot of antibiotics. Thankfully, syphilis being an example, Lyme disease, as well as others. So we don't really talk about antibiotic resistance in spirochetes. Now, it is unfortunately so simple we can't grow it on agar plates, which makes an unfortunate fact that we have to rely on serology to diagnose it. And serology is nobody's favorite way to diagnose anything because it's looking at the shadow of a microbe and so on and so forth. So, but I teach people, it doesn't kill you and it gets better. It's a simple microbe, but it causes symptoms more or less from your own immune response. I don't go through this, obviously. I don't even understand it. It just says that it's good at basically being a stealth pathogen. So it can hang around for a while. You know, literally it can take years and years and years for Lyme to clear. But with natural history, remember after that initial inoculation, you get local proliferation and then immune response, which is going to be your E. migrans. And then it disseminates a lot of times to joints and the nervous system. And it can stay there for a long time. It also goes through the cardiac system initially. So joints, cardiac, skin. And then eventually you do clear it. So eventually you clear it. And then this last fact says reinfection is possible. That's a true statement. However, reinfection is really unlikely if you have a incredibly robust immune response. So if you did antibody testing on somebody and they have 7 out of 10 IgG Western blot bands, the likelihood of them getting another clinically significant case of disseminated Lyme is low. Now, they can get local E. migrans again, but if you have advanced manifestations of Lyme disease, like arthritis, there are not case reports of people getting genuinely new infections causing another case of genuinely new Lyme arthritis. Due to the immunologically mediated mechanism of symptoms, you can have symptomatic persistence of symptoms. That's the worst English of the day. Symptomatic. Anyway, you can have symptoms for a long time and not imply reinfection. So it goes away eventually, and I already talked about that. Doesn't kill you. How much do you guys want to know about clinical manifestations? I don't have to go through all these. I could get into treatment. I don't go through clinical manifestations with patients for the most part because they're coming to me with clinical manifestations, and I'll either reinforce the things that they're complaining of that are consistent with Lyme, and I'll discourage them from blaming Lyme for things that are not consistent. So I guess I'll run through them real quick, but the punchline is a reddish, roundish rash, E. migrans rash. It's seen in some people, not all. It's sometimes in places you can't see, so on your back, where only it would be visible to someone else, etc. And some people just don't get it. And very few look as gorgeous as this one on this slide. So just reddish and roundish. And the bigger the reddish area, the more likely it is to be an E. migrans rash. Okay, and it doesn't occur immediately. The primary differentials are hypersensitivity to the bug bite itself. So that's the top one up here. Tinea, cellulitis, and other such things. So I think the most common one that I see people mistaken is just redness around the tick bite site. That's almost immediate. That tends to be histamine related. Yeah, my body releases histamine whenever I get a tick bite, and I get an immediate red round rash around the tick bite. And but it always is too quick to be the E. migrans. It requires a little bit of incubation period for to be an E. migrans rash. Now you can get a summer flu, so or any flu, any time of year flu from Lyme. So you can get an influenza-like illness with a fever, headaches, myalgias. Now people tend to remember this is cytokine induced, and so as such your joints can hurt. But this doesn't tend to be the oligoarthritis, the single joint or few joints that get genuinely inflamed. This is joint pains, like anybody experiences when they have a significant infection. You hurt all over. It tends to be symmetrical joint pains. Your small joints of your hands and arms and everything hurts. And so I very often hear people complain about that. That's not Lyme arthritis. Those are arthralgias. And they do happen during Lyme, but it's not the same thing as a late stage presentation of Lyme arthritis. And just remember that co-infections happen, so you can get some pathogens that are even better at causing fevers than the Lyme spirochete, Anaplasma, Babesia, Powassan virus. There's a couple other critters that can be transmitted from the Ixodes tick, and some of those are professional fever givers, whereas Lyme is more a stealth pathogen that sometimes causes fevers. So you can get secondary reddish roundish rashes. One of the early phases of presentation is a Bell's palsy. May get that, may not, but and you can just have a person present with a Bell's palsy. If you basically have a person in West Virginia presenting with Bell's palsy, obligated to contemplate Lyme disease, even without any history of known tick exposure or prior E. migrans rash. Yeah, the nervous system tends to be like one of the early involved areas. So you can get a meningitis. Have had people who do end up getting lumbar punctures often have a lymphocyte predominant normal glucose meningitis. You can have other cranial nerves involved. It's not just the facial nerve. You can get the eye. Eye doctors are really in tune to that. Whenever they have somebody come in with a cranial nerve 2 deficit, they're not just looking for syphilis, they're looking for a tick-borne spirochete as well. And I've seen basically almost any cranial nerve can be involved. You can also get a really weird thing that seems like sciatica. Most commonly, I see this in the upper extremities. And so upper extremity sciatica, well, obviously that's the wrong word. Precision of language would say an upper extremity radiculoneuritis. So you can get weird radiating pains in the upper extremities, and that's odd. It's sort of like neck pain, cervical neck pain, and then shooting down into the scapula and hands. Sometimes one side and sometimes two. Even weirder is it can be motor. So we've seen people with paralysis, temporary paralysis of either one arm or both. Really wild. The radiculoneuritis tend to be a little bit later, so that where the meningitis tends to accompany the influenza-like illness, the cranial nerve stuff tends to hit pretty early on too. The heart stuff comes next, and sometimes concomitant or whatever at the same time as the other stuff. And the heart stuff is a myocarditis, and so you can have troponin spilling and all that stuff. And but the classic is the conduction abnormalities with a heart block, which can clinically present as syncope. So I often just ask patients as part of my review of systems, as I'm paging through all this stuff, I'm like, hey, did you get the summer flu or anything like that? No. Did you get Bell's palsy? No. Did you get any weird shooting pains or down your arms or legs? No. Did you pass out or feel an irregular heartbeat, especially particularly slow, and so on and so forth. So those are my pertinent review of systems with patients. Now, it's not uncommon for patients to sort of miss all of those initial manifestations, never recognize a tick bite, never recognize E. migrans, not have any influenza-like illness or meningitis or radiculoneuritis, and they just present with arthritis, late arthritis. That's probably the most common late clinical manifestation we see people present with. And again, this is the one that was classically described as that inflammatory oligoarthritis. And yeah, it's impressive. It tends to be quite swollen, and again, very separate from the multiple joint pain syndrome of acute Lyme that's more symmetrical and all over the place. This is the single swollen, gigantic knee, ankle, elbow. Remember the shoulder and hip, you almost can never visualize swelling in. These are joints with a near infinite capacity for like storing synovial fluid and hiding it from your eyeball. And so I've not ever seen a swollen shoulder or hip, but the ones that are visible to your eyes, you tend to see one or two really swollen joints, usually the knee. And if you do sample them, if the white count is often inflammatory, the average number of white cells I see is about 20,000. It's crazy. It's right about 20. And again, the good news is it eventually burns out in most people, even in people who weren't treated. So this was like the OG of Lyme, the rheumatologist that described it all. And he said, what about people who don't get treated? What happens? Life is not good for a while. I mean, who would want to have a disease not treated that might last 6 years to a decade? Nobody. And so one of the things that I then get back after doing review systems for the patients, I go back and say, hey, why do we treat Lyme disease? Why do we do this? I already said it's not going to kill you and it's going to go away. And I say that it's because it can last a long time, a lot longer than most disease processes. This isn't a few week disease. This is a disease that might last years to years on end. And the reason we treat you is to get you better more quickly. Yeah, and that's sort of that. I do want to mention that even after treatment of arthritis, on occasion, you can get people who have this persistent joint swelling. And it's because it's sort of an infection-induced autoimmune phenomenon. And we don't label someone that quickly. We want to make sure we treat the heck out of them with antibiotics first. And only if they have persistent swelling after multiple rounds of antibiotics, including IV, do we ever label them as antibiotic refractory. But it can happen. It's definitely a thing. How about the brain? You know, we don't know. The truth is we know it can cause meningitis. We know it can cause very, very rarely an encephalitis. It may or may not cause some long-term encephalopathy type stuff. No one knows. We really, really don't know. The known long-term phenomenon I sort of mentioned already is this radiculoneuritis syndrome. I do think chronic inflammation causes the brain fog. You know, I don't think that's unique at all to Lyme. I think it is part of long COVID. It's part of this is a Hep C echo, HIV echo. Any chronic inflammatory disease that stimulates inflammation is not good for your brain, and probably does cause some brain fog and other stuff. I'm gonna skip that one. Isn't it amazing how good G-dub seems in hindsight? I'll keep going though. I'm not going to go too much into diagnosis other than I explained to people very much in detail that what we are testing for is not the microbe itself, but for antibodies produced against the microbe. And this is your immune system, and this is the protective proteins that your body makes to help fight the infection, and it will also keep a memory of that prior battle, probably for your entire lifetime. And therefore your testing might stay positive forever. And so one of the things that that is really, really important is this statement, is persistent IgM and IgGs might stay elevated for life. Now, especially our super sensitive testing nowadays, the screen and confirmation, the two-tiered antibody testing that does not give you a quantitative answer, it just says yes, no, those tend to stay positive. Very rarely do I see them revert. One of the most common reasons for referral is persistently positive tests that people mistaken as persistently active disease. And a lot of times patients are perfectly asymptomatic. They're just nervous and worried because their Lyme serologies have not reverted to negative. They probably won't. Now, the old school Western blot, the immunoblot, gave us more data. It gave us 13 data points, and you did tend to see eventual decline in the number of positive bands over time after successful treatment. And conversely, you could potentially see an expansion of those Western blot bands if you inadequately treated somebody. And so I'm still a big fan of the old school 13 data point immunoblot. with 3 IgMs and 10 IgGs. And so, while that being said, you have to be really, really careful interpreting that. There is no standard approach. I am preaching outside of standard guidelines. And the standard answer for what to do with repeat serologies is don't do them. However, I have personally found it beneficial on occasion. There is no RPR equivalent. So remember, syphilis has the beautifully useful serology known as RPR that tracks disease activity. And you can sort of track your success of therapy by seeing your RPR eventually revert to non-reactive and have a nice nomogram that says how it should be declining with time and so on and so forth. We don't have an equivalent of that for Lyme. So my best guess is really I on occasion use the Western blot bands to help me, but that's all. But I always tell people, hey, this is not a bad thing that your antibodies have stayed positive. It's your immune system and its memory and so on and so forth. Treatment. I remind patients that that antibiotic resistance isn't a thing, so don't worry about that. And by the way, the internet lies heavily on that. They tend to make Lyme completely untreatable and incurable. That's not true. You just have to use the right drug for the right amount of time. The right drugs you can use is really doxycycline or any of the beta-lactams that aren't first-generation cephalosporins. So that being said, try to use doxy. In my experience, doxy is a better oral medicine for treating Lyme than a mox or second-generation or third-generation ceps. I've had fewer downstream sort of inadequate therapies with doxy. Yeah, so that's the oral options, and try to use oral for the most part. Most disease processes will respond to, most manifestations will respond to oral. And I'll talk about the few situations where IV is still necessary. If you do have to go IV, really ceftriaxone is your friend. That's the one you want to use. It's easier, it's got the most data, and it's really the one that we know how to use best for Lyme. The durations are all over the place depending upon your different clinical manifestations. My in general approach for different durations is I go for the longer end of what's suggested. Whereas for most disease processes right now, UTIs, pneumonia, skin soft tissue, the whole trend in the world is fewer days of antibiotics is better. I don't like to leave inadequate therapeutic duration on the table for Lyme. And because I don't have a great marker that says that I successfully treated someone's Lyme, and because people get better slowly, I tend to suggest using the longer duration rather than shorter. And so, for example, an E-migraines rash, you may be told that you can treat for 7 days or 10 days. I give them 14. For arthritis, you might hear 21 to 28 days. I give 28. And it's just, these are fairly benign. Doxy is fairly benign. I go on the longer end so that I don't even have to worry that I undertreated somebody. Okay, so when do you go IV? Basically, almost never. But you can use it in 3 situations. Basically, 3 situations: CNS parenchymal disease, and I'm talking like a genuine encephalitis. Very rare. In general, meningitis, the lymphocytic predominant meningitis, as well as facial nerve palsies, you can get away with doxy, PO-doxy. Do remember, if somebody can't take PO-doxy and has a meningitis, don't give them an oral beta-lactam. It's just not going to work. An oral beta-lactam is not going to get there at a high enough concentration. So you'd be stuck giving them IV ceftriaxone in that scenario. So don't use PO-amoxicillin, don't use PO-cefuroxime. Either use PO-doxy or IV for anything in the brain. Now, the good news is PO-doxy gets there very well. The only places I, again, still use it is if I really have an encephalitic picture or multiple cranial nerves where I'm really worried about their brainstem. Okay, the other 2 areas you can use IV is early on when someone has complete heart block. There's some guidance that says look at the PR interval on your EKG and keep them on IV until that improves to less than 300. Usually that's in concert with when they feel better and ready to go home. So it's usually, maybe 5 or so days of IV therapy. You don't have to keep people on IV ceftriaxone the entire time that they have heart block, just until it's markedly improved. The only other place where we use IV therapy is in people with a persistent arthritis who have almost no response to PO-doxy. And so our usual approach in these oligoarthritis cases, somebody's got a big swollen knee, we'll give them doxy. I'll see them back in about 2 months, because you give them a month of doxy and then I want to wait another month. And I have them come back and I say, how do you feel? And if they say, well, I got better, but then it came back, I give them another round of doxy because they had improvement. If they say, I didn't get any better, we go ahead into IV ceftriaxone. And so really it's for sort of failed PO treatment of oligoarthritis with almost no response. Okay. Now, this is an incredibly important slide, and I absolutely educate all of my patients on this one, that recovery may take time. And so hearken back to that education we provided on strep throat. And we say, hey, remember strep throat was caused by a bacteria making proteins, poisons, and toxins. You take your penicillin, you kill the bacteria, and you feel better. So what happens with Lyme disease, because it's so genetically simple, it's not its proteins, poisons, or proteases or toxins that are making you feel sick, it's your own immune system. What happens is you can kill the bug. You can take your doxycycline. The bug is dead and gone. You can only kill something once. But your immune system doesn't just turn off. And what can happen is it can take a long time to feel better, even with successful treatment. So I tell people that 1 in 4 people, even after successful treatment, doesn't feel normal after a year. But you will get better and you'll slowly improve with time. And the reason we treat people is you get better more quickly than if we didn't treat you. So remember that natural history. You're going to get better, but it could take you 6 years to a decade. But we're going to treat you so you get better in maybe a year. And so the time period of improvement tends to really sort of follow how late your diagnosis was made. So people who are diagnosed at the level of arthritis or late neurologic disease get better much more slowly than those who were diagnosed early at the level of lymphocytic meningitis, e-migrans, or cardiac conduction abnormalities. So one of the reasons we want to treat you successfully so that life goes well. So, but I cannot tell you how important this little tidbit of education is. It's really what keeps people out of the hands of dissatisfaction and seeking alternative medical approaches that might not be indicated. You have to tell them their expectations for improvement may be slow, and the rationale is because it's your immune system that has to calm down, and it can take time. And honestly, I didn't know this up front. This isn't taught well. It's something that frustrates doctors as much as it frustrates patients. I see so many doctors get mad at patients because they come back and see them after they treated their Lyme. How dare you? I did my part. I treated you. Now feel better, right? It's a dissatisfaction even to us as providers when we feel like we haven't helped. This is a Hep C echo, so I'm going to give you the best analogy I can. This is the extrahepatic manifestations of Hep C. So remember the mechanism of the extrahepatic manifestations of Hep C is that prolonged immune flogging from Hep C virus and the immune system just being activated and angry for so long. What do we always preach about the extrahepatic manifestations? We say, be patient. It's going to take time for that immune system to calm down. That arthritic and joint pains and autoimmune phenomenon will hopefully get better, but it can take time. I want to emphasize that will hopefully get better. So just like the extrahepatic manifestations of Hep C, there are some patients who don't get fully better. You know, their sort of infection-triggered autoimmune phenomenon persist, and that happens in Lyme for some people too. It's largely at the level of the joints, and that's what I talked about. They call it antibiotic refractory. So prevention, you know. Prevention's, oh man, good luck. Prevention is move to a different state that doesn't have ticks with Lyme in it, number one. Number two is wait till 2026 when the Pfizer vaccine is going to come out. So maybe move until 2026 and move back. But you can dress like this guy. Kaylee always wants me to dress like that. you can try to kill ticks in the, but punchline is you should try to remember to put insect repellents on and insecticides if you remember. That's the hard part. Is and it doesn't matter what insect repellent you put on. DEET has the most data. Put on something that makes ticks say ew. Then you put that on your skin, DEET. Then you put something that actually kills the ticks on your clothing, like permethrin. And that will reduce the likelihood of you getting an embedded tick like 90+%. But you got to remember to do it. You really got to remember to do it. And the problem is you may not remember to do it, number one. Number two, ticks ride in on your furry friends. And so it's not like you're going to sit in your house covered with DEET and permethrin. A lot of people who get Lyme disease have dogs and cats that snuggle in their beds with them. That's been an experience of mine. They say, nope, I don't go outside. I don't garden. I don't mow. I don't do anything. But my cat does. Well, I guess the cat doesn't mow or anything, but it goes outside and then comes in and snuggles with them and then brings the tick. I'm not going to talk about anything on this slide, but yeah, this is important. If you do pull a tick off, take some doxy. This is a bummer because it's really only for adults, non-pregnant adults. So a lot of times, and again, I'm not a pediatrician, so I can't comment. I think pediatricians are using doxy more and more, but I don't know what the dose would be. But really, the only medication with any prevention data isn't amoxicillin, isn't cefuroxime or any of the beta-lactams. It's only doxy. So what you want to do is if you find somebody who has a Ixodes tick on them, number one, make sure they don't have another one somewhere, because where you got one, you're likely to get another. And so, look everywhere, in crevices, cracks, and dark places, because that's where they like to crawl and hide. And then after you remove the ticks, take doxy, 200 milligrams times 1, reduces the likelihood of downstream complications. I mentioned the vaccine that was taken off the market due to what was considered low consumer demand in the past. But life's changed. Lyme has become a much bigger deal and a lot more common and a lot more concerning. And with time, and there is a phase 3 trials that have completely enrolled, and I know that for a fact because I tried to enroll and they're all closed. But their results are going to come out in 2026, and I think I think the phase 3s have both kid and adult data. So hopefully, yeah, you can try to spray your lawn. You can try to not go outside. You can try to create a tick-free environment for your yard. You can get chickens, guinea fowl, which is awesome. That's the number of people I recommend to get guinea fowl to is high. I should have a prescription pad that says guinea fowl. But just know that only helps if you're catching it in your yard. If you're a hunter and you're going somewhere else, having guinea fowl in your yard isn't going to help. And no, it's really important to explain to patients why they read online that you can't treat Lyme and that it's incurable. The reason is this whole phenomenon of this immunologically mediated symptoms leads to persistent symptoms even after successful therapy. That should be the end of it. That should be the whole phenomenon. We understand that treatment of Lyme doesn't necessarily make you feel better even after I killed the bug, because this chronic immune activation that takes time to resolve. Unfortunately, we like to label things, and boy, by labeling things, we've confused the world. So post-treatment Lyme disease syndrome is what it's called, or chronic Lyme, which is even a worse name for it. And I hate them. I hate them both. I wish those words didn't exist. They are a phenomenon, a syndrome complex that is real. And it's this stuff. It's the long-term sequelae of immunologic activation. So remember I mentioned chronic inflammation causes what? What's chronic hep C cause? What's chronic HIV cause? What's chronic hep B cause? You hurt. You have an activated immune system. I get headaches. I don't feel good. And this is not at all unique to Lyme. This is, when people get mono, what do we know? We know you feel like crap for a while. When you get COVID, that's bad. What do you get? You can get long COVID. What happens after Lyme? These are all really pro-inflammatory microbes. And there's nothing unique necessarily that we know of. We're still studying COVID, but we don't understand the mechanisms. That doesn't mean they're not real. They are absolutely real. I have gone from being a doubter to a full-on believer that this concept of slow to resolve inflammatory process is real. And absolutely telling your patients, educating them about it, and letting them know that we believe you, we hear you, but the problem is we don't know what to do for you, and that it will get better is the issue. And so I feel like the medical literature poo-poos it to some degree because it always says these are subjective symptoms and we can't find any objective evidence of anything wrong. So what? You know, that was for years and years. That's why we told people Hep C had no symptoms. And then we started treating it and people felt better. And we said, oops, sorry, I guess you did have symptoms. I just didn't know. Same with post-treatment Lyme. It's the exact same phenomenon. It's a chronic post-inflammatory or ongoing inflammatory syndrome. We just don't know what to do about it. There have been trials that say, does it exist? Some people say it doesn't. I think it does. Enough patients of mine say it does. People have tried to define it for whatever that's worth. I hate that stuff. Just know that it basically says I can't find anything on physical exam, but my patients have all the symptoms. And we don't know how to help people in that scenario. So it's that vacuum of knowledge that leads to trouble. We know that ongoing and more antibiotics don't help. On occasion, people will say that I feel better when I take Doxy. If anybody's taken Doxy, besides the GI side effects, it does have a little metalloprotease anti-inflammatory activity. So it's like you're taking a low-dose NSAID to some degree. And so, yeah, sometimes your joints feel a tad better on Doxy in between your diarrhea and puking episodes. So, but I would not advocate you stay on Doxy long-term for all the reasons that you shouldn't take antibiotics all the time. But anyway, this is the problem, is we need to explain to our patients that their post-treatment symptoms may persist, they'll gradually improve, that they can spend a lot of money and go see Lyme literate medical doctors, and they'll get better in 6 months, or they can do nothing and get better in 6 months. But know that a lot of times these, I do think probably well-intentioned alternative medicine practitioners can on occasion do harm. And I've known some of these guys, they're not bad people. They believe what they're selling for the most part, but boy, they're selling them for cash for the most part. And they can on occasion do harm. I will leave it at that so I don't bore the heck out of everybody else. But I just want to show people the bad things that can happen from not teaching your patient about post-Lyme treatment. So they can seek alternative medicine providers that have literally caused death via ongoing antibiotics that cause C. diff, sticking PICC lines in people for a year and causing fungemia. And I think the part I have highlighted down below, the most important and most precious of all of this is false attributions. So you really, what you don't want to do is become so obsessed with Lyme is that you don't pay attention to new symptoms. So one of the things I tell patients is, yeah, you might not feel great for a while after treating a Lyme, but don't accept and don't let any internet article tell you that I can garner new symptoms. So if you suddenly start having night sweats and weight loss, don't say that's my Lyme, because you can miss cancer, you can miss lymphoma. If you suddenly develop a new pain syndrome, it's not a new manifestation of previously treated Lyme. So the most important message there is don't have false attributions that can mislead you and lead to a missed alternative diagnosis. So I have some other crap on here, but it just more or less says everything I already said. And this is interesting. I always wondered why Lyme gets so much attention and stuff like that. It's because it's Americana. It's okay to get Lyme. It's not okay to get syphilis, right? You don't run around with a big sign that says I have syphilis, help me. But syphilis can, but it's okay to get Lyme. Like you can talk to your grandmother about why you got Lyme, because you're out with your dog and mowing the lawn or something. But summary, it's a spirochete. It goes away, doesn't kill you. Now I have rarely, because I actually have seen it cause fatal process, but it's exceedingly rare. There's more and more around. We have it in West Virginia nowadays. We need to remember what it can and can't do. It certainly can do a lot of things, but it can't do anything it wants. We want to make sure we successfully explain diagnostics to patients that it's antibodies. They may stay positive for life, but we can kill this microbe. It doesn't become antibiotic resistant, and that they may have some sort of non-specific symptoms that last a while, and that's sort of consistent with a lot of other disease processes like long COVID and EBV as well. We don't know if it's the same mechanism. Honestly, we don't understand long COVID enough or any of the other disease processes to tell you with certainty, but as a concept, it's not unique. So I open it for questions. We'll go from there. Sorry about droning on for an hour.
So, Dr. Gulifoose, it sounds like you're just pretty liberal with that single dose of doxycycline for
Oh man, I'm
prophylaxis.
completely indiscriminate. Yeah, so much so I give people who've seen me for Lyme, I give them every patient I see, even if they've had successful treatment of their previous Lyme, they've evidenced to me that they live in a tick-rich environment or their behavior puts them at risk of tick bites. So I give everybody a prescription for doxy to keep in their closet. Now, it's just 200 milligrams times 1, not 28 days. And I say, hey, because ticks have a nasty habit of biting you on a Friday or Saturday, when your option is urgent care, ER, or nothing. And so I'd rather have you have the doxy at home. And I don't care if you take 200 milligrams as long as you're not pregnant. Yeah. Yeah. I give it and I take it a lot, by the way. I wish I'm a tick magnet. And I pull these things off me two this week. And it's just, it sucks, but you got to take some doxy so you don't get long-term badness down the road. People always ask about the mox and beta-lactams. There's just no data on it. So I've not done it, especially for kids. I feel bad. I defer that to a pediatrician. I don't know what I'd do there.
I tend to just have the discussion with the parents, and if they're big enough to swallow the pills, they probably get the doxy.
Yeah, I know. There's almost no harm. Yep.
And one dose probably, I mean, the issue is staining teeth, I think, and it's like one dose is not going to do that to my knowledge. I think Dr. Leonard was saying the same thing, that,
Yeah.
We can give it safely. I mean, in the bad old days when I was in residency, we gave them full courses of doxy for Lyme disease. It was rare then, but we did it.
Yeah, and again, I think the data is that it's not even the doxy, it's some of the old tetracyclines that had the tooth staining. And as Dr. Leonard is writing, the major issue is pregnancy. It's the major prohibition. That and allergy. I've not seen many people with a tetracycline allergy. It's extremely rare, but in those scenarios, my approach has been with a really allergic patient who actually has Lyme. I refer them to an allergist. I really do, because I've had a couple of people with beta-lactam and doxy allergies. Azithro just doesn't have enough data for me to confidently say I'm treated somebody's Lyme successfully. And because we don't have a biomarker to follow, I tend to refer them to allergy immunology. And again, remember, that's 9 out of 10 people with an allergy history of beta-lactam are not going to have it. And so a lot of times I'm able to get the allergist to clear me and then successfully challenge them. But thanks for listening to me again, guys. And even through this bunch, but it's man, I can't tell you how much worse Lyme has gotten in the past, like 5 years even. It's gone ape. This year's is even worse. So I'm worried what happens next. We have had some more Atlanoplasma this year. I'm hoping we don't get Powassan or anything else. And I have not seen Babesia locally acquired. So
Have you seen any of the starry, the Lone Star tick?
Probably not. I've not personally seen it. Or at least I have. If I've always assumed it was E. migrans, which again is indistinguishable from E. migrans, and we'll go ahead and treat it as such. But I don't know how I differentiated. It may be people who aren't seropositive, but it's such a challenge. It's a great question. I've not sure I've ever seen it. It's more a southern disease, but who knows? Ticks don't know that. They move all about. The punchline is I see a reddish roundish rash from a tick bite, I'm treating it regardless.
I guess I know of one case in Hardin County a couple years ago.
That's awesome. In the chat, Dr. Leonard has the dosage for kids for the prophylactic dose. So I appreciate you there, man. Thanks.
All right. Does anyone else have any other questions? No.
Has anybody seen any
Well,
manifestations of Lyme? Raymond, you had any? You had some good ones before, brother. Yeah.
I really have. I had a kid, 7, 8, 9. I didn't see when he presented, but he had third degree heart block. Heart rate was 38 in the office.
Wow.
I've had a few Bell's palsy. I've had one friend whose boy had meningitis. I see lots of knees swollen.
Yeah.
And then I had that girl we talked about. My goodness, she just, I mean, her immune system just wiped her out, but everything's normal now. We treated her Lyme disease and thyroid was normal. Everything else was completely normal, or normalized, I guess. So yeah, once we killed the Lyme and her immune system calmed down, she fixed herself.
I don't know if I told you guys this. I think I did. We had an endocarditis from Lyme, like a genuine endocarditis, like valvular damage, destroyed, stroke, all that. And then shortly after that, we talk about the radiculoneuritis as a pain syndrome. We had it in short order, complete motor loss. So we had a person with bilateral inability to move their arms. They called it a man in a barrel syndrome because they couldn't, although it was a woman, but they couldn't move their arms at all. And they got better. So it was just treatment and time. And then we had one person with another brachial palsy that couldn't move their right arm. So it's a neurotropic bacteria. It really is. And I always think of it as pain syndrome, but remember motor too. Man, I want that vaccine.
all right, guys. So our next session is going to be on June 13th. And it's going to just be like you guys as the participants presenting cases and talking about different stuff. And that'll be our last session for, I think it's like technically the first part of the year. I will send around a follow-up email with everything. And remember, you can access the slides online. Dr. Gulifoose, well, he left a little early. They should be online if I can have him forward them to me. But thank you all for joining, and I hope you have a great rest of your day.